Okay, so a little bit of context to the title of this talk. When I was meeting with Dana and the meeting organizers, gosh, probably more than a month ago, introducing myself, sharing a little bit of my family's story and my personal and professional journey, raising three children, but one who has significant disability and due to a neurogenetic disorder. But is such an incredible valued member of our family and our community. I was sharing our story, and at the end of we were kind of chatting through our journey to getting here, and Dana said, "Wow, Liz, how do you do everything?" And I was very quick to say I don't. I don't do everything. I don't come close to doing everything. And we then kind of pivoted and we talked about all the ways in which I don't do everything and I can't do everything. And they said, that's what we want you to talk about. And I was a little taken aback. This is not a perspective that I've ever been asked to give a talk about. And so, but I love a challenge. So here we are. I will share from the beginning. I am an open book. There is no question that is off limits. I'm glad that we have time at the end for thorough question and answer, but I'm really just here today to share my story. So I will give a brief introduction into myself, and I'll talk a little bit at the beginning about Evelyn's journey to diagnosis. And I used to say that I am where I am today in spite of Evelyn's diagnosis. But the further I get into this journey, I really realize how much all of my children, but Evelyn's journey and her neurodiversity has really shaped where I am today, both personally and professionally. So we'll talk about her journey to diagnosis, and we'll talk about how that's really shaped my professional journey. But I think what really the takeaways here are really lessons that Evelyn has taught me as a parent of a child, a neurodiverse child, and really the takeaways to how to do it all, which really means doing what's important and not at all trying to do it all. I have a number of disclosures, none of which are at all relevant to what I will be talking about today. But I think the most important disclosure is that, again, I am absolutely no authority on this topic of self-care. I am really just sharing our own story and journey. So the most important part of my introduction, I am mom to three beautiful children who are all of a sudden looking quite grown into little adolescent and pre-adolescent humans. So on the far left here is Evelyn. She is now 11 years old, and she has a rare neurogenetic syndrome called Angelman syndrome. And she was diagnosed around the time of her first birthday. Evelyn, as most children with Angelman syndrome, is nonverbal. That does not mean she does not communicate. She's an incredibly effective communicator, albeit through wildly non-traditional and non-conventional ways. But she's incredibly effective at making her needs known and getting her point across. She has epilepsy. She has had epilepsy since she was about a year old. Evelyn struggles with a lot of the things that children with Angelman syndrome and people with Angelman syndrome do. She has balance and coordination challenges that, while she's very functional now at navigating her surroundings, that took a lot of hard work in the early years to get there. And as she's getting into puberty, our world now is really about managing behaviors that have come with probably growing frustration around inadequate communication or not communication that's not as effective as she would like it to be, and how that manifests in day-to-day life, as well as anxiety. Evelyn has two typically developing siblings that are her world. I think Evelyn has thrived by being a middle sibling that was always trying to keep up with an older sister who she absolutely adores, and a younger brother who she is constantly dueling with. Charlie and Evelyn have an incredibly typically dysfunctional second and third sibling relationship. They fight like cats and dogs and do everything they can to drive each other absolutely nuts. So I will say it's been one of the joys of parenting to see how typical their relationships are despite the challenges that Evelyn has. So, in addition to being a 24-hour-a-day caregiver and parent to Evelyn, I am also a busy clinician. So, I am trained as a pediatrician. I spent a couple of years as a general pediatrician. We'll talk about this a little bit later, but now practice as a pediatric geneticist at the University of North Carolina. And really, I am a clinical trialist. 95% of what I do every week is run clinical trials or study visits looking at interventional therapies for kids with neurodevelopmental disorders like Angelman syndrome and Rett syndrome, Duke 15q syndrome, and then a second set of disorders that are a progressive group of lysosomal storage disorders, the mucopolysaccharidoses, Hunter syndrome and Sanfilippo syndrome in particular. This is the dream job that I never knew that I wanted. And we'll talk a little bit about how my career evolved into this. And I threw this last bit in. I'm also an advocate. As a parent, I wear a lot of different hats in the Angelman syndrome community and in the genetics community. I serve as the chief medical officer for the Angelman Syndrome Foundation. And in that capacity, I do a lot of different advocacy work, both in Capitol Hill in DC, and as well as, kind of on the front line meeting with newly diagnosed families and helping them traverse Angelman syndrome throughout the lifespan. So how in the world did I end up here? I think a lot about this because, again, this is the dream job that I never really knew that I wanted and did not know existed. So, if I think back to kind of my earliest, how did I get here? What were the earliest signs? I was an incredibly inquisitive child. I was always asking questions. I'm sure I drove my parents absolutely crazy because Charlie is now the embodiment of that in my home. He is my most inquisitive child who is asking me 4,000 questions a day. But I was always asking questions. And I was always fascinated with science. From a very young age, I could be found in the yard trying to identify and study chlorophyll in all of the green plants in my yard. That was my passion as a child. I was a little bit of a quirky kid, but it was very clear from an early age that science was the direction that I wanted to go. And then I decided I wanted to be a doctor when I was 10 years old and I fell off my bike and I broke my arm. I thought seeing my arm on that x-ray machine was the absolute coolest thing. And from then on, you could not have convinced me that there was any other path for me. I was going to be first an orthopedic surgeon, then a lot of different types of physicians throughout childhood. But ultimately, it was really the tie that bound was this kind of endless curiosity. So perhaps not surprisingly, when I got into college, at UNC, I'm a UNC lifer, I decided that I wanted to kind of get my feet wet in research. And again, it was kind of this driving question of how do we understand the human condition? How do we understand what underlies health and development? At this time, I was really interested in oncology. So I joined a lab looking at whether we could predict response to novel therapies through the genetics of a pancreatic tumor. Back in 2010, when we published this paper, this was really novel. This was kind of the beginning of thinking about using molecular genetics to be able to determine treatments. And the oncology field, in so many ways, has led the way. Even in the rare disease community, we're very much still following in the oncology path. But this was really my first foray into genetics. This continued on as I was a medical student. At Wake Forest University, I continued doing cancer genetics research. I was very interested I had a fabulous mentor in medical school who was looking at BRCA related cancers. And so I spent my medical school years doing research with him, decided I wanted to be a surgical oncologist, which thankfully I decided not to do. When I went to residency, I was really pulled towards pediatrics. I knew that I loved children. I knew that I loved working with children. But at the time, I really thought that I would be a pediatric oncologist and I would focus on the genetics of pediatric cancers. But as all good plans do. They change. I have taken no shortage of hard left turns throughout my path to get here. And that first hard left turn was really into the rare disease world. I guess it probably wasn't the first. It was a pretty hard left turn to go from a surgical residency to a pediatric residency. But the first, the most jarring hard left turn for me was into the rare disease world. So it, as you know now, was this beautiful middle child who was born after an incredibly uneventful pregnancy. She was my second. There was nothing different about this pregnancy. She was born at term a full 2 pounds smaller than her sisters, which made us all scratch our heads a little bit, and was a fiery little thing, a little redhead that burst onto the scene and had, from the moment she entered this world, I wondered if there was something different about her. I grilled the obstetrician in the room with me. Do you think that she had decelerations that during delivery that might have caused some, loss of oxygen to her brain? She had this cry that was very high pitched and was just, to me, sounded like the cry of a child who had a neurological issue. I'd spent plenty of time working in the NICU as a pediatric resident, and there was something about that cry. We were reassured. We were discharged home from the hospital with a lot of reassurance and close pediatric follow-up. But by 5 days old, I was asking the pediatrician, "Are you sure you're not seeing anything on exam that's worrying to you?" And, again, just a lot of reassurance. By 2 weeks old, though, it was clear she could not figure out how to feed. And again, she was not my first child. I had nursed my oldest, and this Evelyn could not figure it out for the life of her. So she was not gaining weight like she should. We were constantly every other day back and forth to the pediatrician's office. By 2 months old, we were being referred to GI because of concerns that maybe this was just really, really bad reflux that was driving this really challenging feeding issues. We had seen lactation. We had seen all of these experts, and nobody could really figure out why she couldn't figure out how to eat. At this point, we had pivoted. We were doing every bottle on the market, trying to find some way that we could feed her. This just really felt biologically off, that I could not figure out how to get this child to eat. By 4 months, I self-referred to early intervention. It was, I think, like February at this time or January, and our appointment at early intervention got snowed out. And so it got rescheduled, but it didn't get rescheduled for some months down the line. I think we didn't actually end up seeing early intervention for the first time until it was 7 months. And at that time, again, there was a lot of reassurance that said, yes, she's behind. You're not crazy, but she's not so far behind that we think, that she needs early intervention and that there's worth doing anything else. And I was like, well, that's because I'm bullying her to do all these things. I had bullied her into rolling over. I bullied her into learning how to sit up. So we went to our 9-month checkup. Again, she's still, significantly failure to thrive, horrific reflux. I'm spending 23 hours a day feeding her. And at this time, I was a research fellow at Hopkins, and I had essentially all but abandoned my post as a research fellow. I was really only there for the half a day a week that I needed to be in person. The rest of the time, I was at home feeding Evelyn. So we went to her 9-month visit, and I had told myself, if nobody believes me at this visit, then I'm going to have to take matters into my own hands. I've been telling everybody literally since the moment she was born that I was worried, but nobody's listened. And so after that 9-month visit, I couldn't get my pediatrician worried enough about this to make a referral. And so at the time, I had actually transitioned from being a research fellow at Johns Hopkins to being the pediatric chief resident. And so I was sitting in a position of incredible privilege. I had the privilege of access. I could pick up the phone and call anybody I needed to within the Hopkins system. Fabulous institution, medical institution, right? So I picked up the phone and I called the neurodevelopmental team and I said, somebody's going to see my child this week. It doesn't matter who it is, but somebody's going to see her. And they did very graciously, very much professional courtesy, got her in. We're extremely worried, ordered all of the testing, which about a month before her first birthday came back consistent with Angelman syndrome. I wanted to highlight the kid in front of us here, right? I get it. She looked like a healthy baby. She is beautiful. She was a gorgeous baby. She was smiling. She was engaged, if anything, too engaged. I can remember the daycare saying, my oldest, you had to fight to get a smile out of her. Like it was really hard to get her to engage. And Evelyn, you'd walk in the room and she'd just beam at everybody. And I said, well, yes, despite the fact that the child can't eat and she's horribly failure to thrive and she's vomiting everything in her system, yeah, she's happy, which I guess is a blessing. So we got this diagnosis and it rocked our world. At this time, I was the pediatric chief resident at Hopkins. I had a career path in front of me. I had a career lined up for me in academic medicine, in pediatric academic medicine, in the research realm. I thought this was exactly what I wanted. This is what I had worked so hard for. That year that I had as pediatric chief resident was really a blessing. So it was a busy year. It was a hard year, but I felt incredibly supported to do what I needed to do for my family. I did my job and I did what I needed to do to take care of Evelyn. This was a sweet picture of Evelyn. I believe around 14 months old when we were doing our first EEG. Children with Angelman syndrome, her subtype of Angelman syndrome, have about a 95% risk of going on to have seizures. And so I think this was just a baseline EEG and not one because we were worried about symptoms. But she did ultimately end up going on to be diagnosed with epilepsy in that first year after diagnosis. And in hindsight, she was probably having seizures even before then that weren't recognized because we didn't know that she had a diagnosis of Angelman syndrome, again, until close to her first birthday. And, the average age of diagnosis for a child with Angelman syndrome is between 12 to 24 months. So by all accounts, this was still an early diagnosis, but I'd had concerns since the moment she was born. So when I think about kind of the barriers to her diagnosis, first and foremost and pervasively across that whole first year was really the need to convince a clinician that there was indeed a clinical concern. In pediatrics, there's very much a wait and see approach. I know this. I was trained in this doctrine. I was trained that myself, that, without a tool to intervene, there's no need to there's no urgency to making a diagnosis, which I think many of us in the rare disease community would argue is just not true. There's a whole lot of value. Connecting to community, just putting a name to something, not feeling crazy that you're the only one in the world who thinks that there's something going on with your child. Nobody else sees it. So really overcoming this wait and see approach was really, that was challenging. There was a lot of, if I'm being honest, trauma in that first year of life, kind of about the constant reassurance that came with all of those constant medical visits where I was concerned, but I was constantly being reassured. For most, long wait times to see specialists for diagnostic testing is a huge barrier to diagnosis. When I ultimately decided that I wanted to go back and be a geneticist, it was really because I was like, well, I'll just be one more good soldier in that fight of, providing more geneticists. There's a huge shortage of geneticists and neurologists in this country, and that's who largely gatekeeps genetic testing, which is not necessary. But it is kind of the way things are done right now. And so I thought, well, I'll be one more person and hopefully that shortens somebody's diagnostic odyssey. And then, of course, there's insurance barriers to appropriate testing. While we didn't struggle with long wait times to see specialists because of this privileged position that I was sitting in, we definitely struggled with insurance barriers. Evelyn's testing was ultimately denied because it was on a buccal swab, and that was considered experimental at the time, even though this was diagnostic testing that really was able to tailor our management and I think cut down on healthcare utilization because we were no longer having to see doctor after doctor to try to figure out what was going on. But I think the longer I sit in the rare disease community, The longer I realize that Evelyn's story is not unique. This is, if you talk to anyone in the Angelman community, but really the more I meet with families across many rare disease communities that I work in, this is not unique. This is a very similar trajectory, and we have the tools that we need to not have this be this same story for all of these different children. But for a child with a rare disease, the diagnostic odyssey typically can last between 4 to 7 years. Again, by all accounts, Evelyn's diagnosis was early. Certainly modified by several factors that we've already talked about. And many children, again, as we saw with Evelyn, see a number of specialists and undergo a number of diagnostic tests before receiving an accurate diagnosis. And some studies indicate that families visit more than 10 physicians before getting answers. In my position with the Angelman Syndrome Foundation and in my current role as a clinician in the Angelman community, I meet with a lot of newly diagnosed families. And even this week, I had an opportunity to meet with a family who just received a diagnosis at 40. Their son is now 46, but he received a diagnosis at 40 years old. Throughout his life, he'd marched through a number of different diagnoses, from autism to, I think at one point, CP and, kind of intellectual disability, NOS. And finally, at 40, the parents had kind of relentlessly pushed and asked for the genetic testing that ultimately provided them an answer that then unlocked an entire community of families who are walking the same road, clinicians who understand and can counsel about the unique challenges to an adult with this specific subtype of Angelman syndrome, as well as unique therapies. I mean, I counsel families all the time. The number of times that a genetic test result I'm going to be able to pull a drug off the shelf and say, here's what we know is best for your child, or here's some novel, disease modifying therapy. It's vanishingly small. But Angelman is one of those scenarios where a diagnosis does open up a door to participating in clinical trials, at least, of potentially disease modifying therapies. And so, and at least, understanding best practices and standards of care and how to manage the common symptoms symptomatically of Angelman syndrome. So, to me, this is inexcusable in 2025 that we are still in this place. So that's our families, how we got to Evelyn's diagnosis. So how did this impact my professional journey? So we'd have to go back again. So I was remiss in not mentioning that my oldest was born when I was in residency, and inevitably this ultimately shifted what I thought I wanted to do. I told you I came into residency saying that I wanted to be a pediatric oncologist, and that's true. And then Sloan, my oldest, was born, and as all of our children do, they change us. They rewire us on a molecular level, and I knew, coming back from maternity leave with Sloan, that I did not want to be in a job where feeling like doing my job well would mean that I was at the hospital at midnight with new diagnoses on a regular basis. It felt like too much of it felt like an emotional burden that I wasn't going to be able to handle. It also didn't help that I came back from my maternity leave with a 8-week-old to a child that had basically the same birthday as Sloan on the pediatric oncology floor, with a terminal cancer diagnosis. So she inevitably shaped some of those first early kind of left turns. And then, like I said, Evelyn was born during my research fellowship and diagnosed when I was a chief resident. And again, I had this very clear path set for me. Coming out of this chief role was into an academic position. You climb that academic ladder and you have this future laid out for you. But it was clear to me, at the end of that chief year, Evelyn, again, we were navigating her new epilepsy diagnosis. We were navigating the amount of therapy that it was becoming clear that was going to require for Evelyn to learn to do basic tasks: feeding therapy, occupational therapy, speech therapy, physical therapy. All of those therapies were going to be necessary. And how in the world could I do that with a full-time academic job? So there just became this nagging voice of, I can't do it all. I think it started with Sloan, and then Evelyn, was the real hammer that said, you maybe you can do it all, but do you really want to try to do it all? So I left academia. with these two precious peanuts, the world's best big sister trying to quell a probably screaming Evelyn with a pacifier. And I joined a private practice as a general pediatrician, and I worked part-time. And I tell people all the time, actually, that I think that was the last time that I was truly mentally well, because I only worked 3 days a week, and it was glorious. I had time for me as a person, and I had time to give to Evelyn and my family. Um, I learned how to be a mom of two kids, eventually three kids, during that private practice stint, to one with significant needs. And this is where some of that self-care starts to trickle in. We hired our first au pair, which was our first live-in childcare. And this really was a game changer to me, not because I could work more, but because I felt like there were now three adults to help kind of distribute the attention. And when I needed to be able to give more attention to Evelyn or her newborn brother, Charlie, I was able to do that because we had this, we had all these extra hands in our house, which was lovely. And I should say, we've never lived in a house big enough to have an au pair, and we have somehow made it work. We've lived in every square centimeter of every house we've ever lived in. Oh gosh, I saw lots of ears, butts, and throats as a general pediatrician. I learned what's normal. I learned how to I learned how to be a general pediatrician. But because of my training at Hopkins, and because I was caring for a child with complex healthcare needs, more and more my practice became caring for children with complex healthcare needs. Not news, but needs. And this was hard. It took a lot. It took a lot of me. And I think there was always this inkling that while this was incredible, I was very fulfilled in doing it. It wasn't my forever. I wanted to be on the other side of that table making these diagnoses. I felt incredibly limited by what I was able to do in private practice for children that I knew needed diagnostic workup, but I wasn't able to get. I actually did convince my earliest practice that I should be able to send genetic testing. And I will tell you, their biggest anxiety was, well, you don't have a genetic counselor with you. And so what are you going to do when you get a genetic diagnosis? And so I made an alliance with the local children's hospital that said, if I'm going to send this testing, I need access to a genetic counselor within 24 or 36 hours if I make a diagnosis that really needs urgent counseling. And they were more than happy to do that, as are we now in academia. On the other side of this, I now say that's something that we provide to our general pediatric colleagues all the time, because I really don't, I believe deeply that that neurologists and geneticists and specialists really shouldn't be gatekeeping this, because primary care pediatricians are the ones who are on the front line. They're the ones doing those screening assessments. They're the ones then frustrated and worried about the year-long wait times for their kids that they are having to send specialists for this testing. So empowering that primary care provider to do that became kind of an important thing that I was stewing on as a primary care provider. So perhaps it's not surprising that with all this baggage, not my children, my personal baggage about the diagnostic odyssey, how long it took us to get to a diagnosis when I had been worried from and expressing these concerns from the moment Evelyn was born. This access to testing issue. And I think additionally, kind of having then now lived in the neurodiversity community, the disability community, this kind of growing unease that I had about kind of shifting the narrative around disability and not having it be this negative thing that we talking about the beauty that comes with neurodiversity and the beauty that comes with disability, the very normal part of humanity that is disability. So I think all of these were driving factors that ultimately led me to decide to leave the cozy, comfy, general pediatric job that I had and go back into the academic world at a particularly hairy time. So this is one of my favorite pictures of Evelyn and Charlie from those early days of Charlie joining and rounding out our trio. But this was about the time when I decided I was going to go back to fellowship training. So I returned to training in 2019 it was a medical genetics and genomics fellowship. And again, that the really driving force here was around this diagnostic odyssey, and again, shifting the narrative around neurodiversity and disability. At the time, this is how I felt, this picture of my eldest at the time. I felt like this was a completely nutty decision. Of course, as soon as I made this decision, we entered into a global pandemic. I was knowingly putting myself into a position where I was going back to being on call 50% of the time. That's a wildly terrible decision. And so during this time, we transitioned to having our second au pair. And then eventually, as that au pair transitioned back to her home country, a third au pair. And that was really how we survived those early years. So I came back to fellowship in 2019. Again, with this idea that I was going to be a really good diagnostician. I wanted to be able to diagnose children. I wanted to be, I wanted to be the geneticist. Geneticists often get a bad rap. They are often the person who meets families on their most challenging day and gives news that people may or may not want. In my case, while this was an incredibly challenging news, this was not the news that we expected to have an Angelman diagnosis. But in a lot of ways, it was like the weight of the world lifted off of me. But I still have a lot of beef with the way that the news was delivered. And a lot of families do. They carry this. They don't have any desire to go back and see their geneticist, because that geneticist was the person who said, go, here's your diagnosis. They gave them all of the terrible things. Most people in the Angelman community, at least, tell stories about how they say their geneticist said their child would never walk, they would never talk, and that they would, never be able to communicate or do anything, and that they would have profound intellectual disability, which, those of us living in the community know is just not true. At least that's not the entire story. And so I desired to be something different. And as I got into fellowship training, there were definitely, as I think back on those kind of formative years of figuring out what I was going to do, I knew that ears, butts, and throats were not my forever. But I really still wasn't sure what I was. I mean, yes, I could go back and just be a general geneticist and be in the clinic and see patients and help mitigate that diagnostic odyssey. But it wasn't clear to me that that was my only kind of mission. And as I think back on those formative years of fellowship, there were definitely a handful of children and stories that shaped how I decided what I was going to do with my time as a geneticist. So the first is my little friend Blaze. All of these children's photos and names are shared with their parents' permission. So I met Blaze when he was about 2. He had a uneventful pregnancy, and then in early infancy, fairly normal early infant development, and then clear developmental delays had emerged by the time that he was around 1. They began seeing specialists trying to understand, was this CP? What was the diagnosis going to be? Ultimately, he saw a neurologist who felt compelled to send a large battery of testing, which identified that he had a congenital disorder of glycosylation, PMM2-CDG. PMM2-CDG it's one of the most common types of congenital disorders of glycosylation, and we can see multiple different phenotypes as a result of PMM2-CDG. We can see an early, very severe infantile presentation. That is not what Blaze had. We can see kind of this neurodevelopmental picture with abnormal biochemical profile and significant challenges with balance, ataxia, communication, which is the form that Blaze has. And then we can see a more attenuated adult version where we just see kind of a stable adult disability. But Blaze, I met him as we were counseling about this new diagnosis somewhere around 2. And his mom came to me about 6 months later and said, I've been doing my research, and there is a drug that may potentially be able to help Blaze. It was a drug that was in development for a different indication. It was in development for galactosemia. And she said, I'd like to approach the company about using it off-label in a single patient IND for Blaze. I was a young fellow at the time. I was, of course, eager to think about this problem and whether this was something that we could solve for this idea of getting early access or expanded access to a drug that was in development for a different indication. And I had a really fabulous mentor who was willing to explore this with me. And so with their support, we applied for a single patient IND to the FDA, worked with the company, developed a protocol, and were able to get Blaze onto this investigational drug around the time that he turned 3. This was a picture of him taking his first dose. He has his little IV in place because he was doing his PK sampling. He was having, kind of frequent blood sampling because this was the first time that this drug had ever been used in this patient population. And to complicate matters, this type of drug has potential liver toxicity, and that's a primary kind of disease manifestation of this disorder. And so we had to do a whole lot of safety monitoring and safety testing. But Blaze was such a trooper. He did it with a smile on his face. His family was incredible. And ultimately, Blaze is now, 6. I think he's in first grade. I just got a picture of him showing off his smarty pants self spelling, writing his name, albeit with a very scribbly, ataxic writing form, but he's doing it. We will never know whether Blaze would have made these gains without this investigational drug or whether this was the trajectory that he was always going to take. But it was a really incredible story of hope for me, of working with a family to be able to try something where there's nothing. At the time, there were no clinical trials that he was eligible for. There were no other drugs in development for his disorder, and he's really done phenomenally. Okay, the next kiddo in my stories, this is Charlotte. Charlotte came to me for a second opinion when she was 7 months old, and she was diagnosed with a horrific, always lethal, relentlessly progressive, infantile onset lysosomal storage disorder called Niemann-Pick type A disease. Her family had received this diagnosis and were very accepting of this diagnosis and her prognosis, but they said, we want a second opinion to make sure that there's nothing that we could do to either extend her life or make what limited time she has more comfortable, which was an incredible mission. They came to me similarly around the time of her diagnosis. There was a drug not targeting the progressive neurological symptoms, but targeting the physical manifestations of her disease that was nearing approval. It had not been used or proven to be safe in children her age. And the general thought in the community was that it might be unsafe to do so, that that she might not be able to tolerate it, that she might be too sick to tolerate that. But they came to me and they said, we want to try. And furthermore, there was a second drug that, very similar to Blaze, in mouse studies had been shown to slow down progression of the neurological disease. And they said, we want to try both of these. As you can imagine, this was a little bit more challenging sell here. So I, again, with that same mentor, we thought through this rationally. My first question in all of these is this safe? And what is the potential harm that we might be causing? Because this is a child who does have precious time left here. And the last thing that I want to do is make that more painful. And inevitably, if we're going to enroll in any sort of research, we are medicalizing in a way that comes with, risks and discomfort. And so, after a lot of thoughtful consideration and working with the family and working with the drug company and working with the patient foundation and working with the FDA, we were able to design a protocol, and we were able to get Charlotte on a protocol looking at exploring both of these different approaches. So the enzyme replacement to really try to improve her physical symptoms of disease. She had massive spleen enlargement that was making it difficult for her to eat and sustain weight gain. With that enzyme replacement, we were able to shrink that down pretty dramatically and make her more comfortable and able to eat. Incredibly important in infancy throughout life. This is an incredible source of comfort. And with the other drug, we were able to demonstrate that we were able to safely use that drug, and that the one that was more targeting her neurological disease, and it seemed to be well tolerated. And so, unfortunately, as expected, Charlotte did pass away from her disease around the expected age that she would have, around just after her second birthday. But there were so many lessons that Charlotte taught me. We're actually just past her fourth birthday now. And so I've been reflecting a lot on Charlotte and what Charlotte taught me and how she shaped my career. Um, Charlotte, Charlotte and her family taught me that you can hold profound grief and joy in the same space. They taught me that you can live in spite of, by all accounts, dying. She lived. This little girl saw the beach. She went to concerts. She was a sideline sister at all of her brother's football games. She she did everything, and she was a trailblazer for her patient community. We've now shown that we can use the enzyme replacement safely in her age group, and it can improve symptoms, and that's incredibly important from a quality of life standpoint. And we showed that the other drug was safe and well tolerated. We saw no safety side effects. And so that's then enabled them to think about using even higher doses that may be disease modifying in other children. So Charlotte was a trailblazer and absolutely beloved by her family, and an incredible privilege to work with. And the last kiddo that I want to share with you is Sadie. Sadie is now probably 9-year-old, but when the time when I first met her, she was 3, I think, about in this photo. And Sadie has Sanfilippo disease. Sanfilippo is a also relentlessly progressive, albeit slower than Niemann-Pick type A, lysosomal storage disorder, so progressive neurodegenerative disorder. Sadie had been diagnosed earlier than most in early infancy, and that allowed her to have access at a really young age to a clinical trial that was promising and did seem to slow down her disease progression, or at least stabilize it. And so when I met Sadie at 3, she was speaking in complete sentences. She was incredibly smart. She was spelling her name. She was able to say her ABCs and sing full songs for you. Unfortunately, the company that was developing her drug decided for financial reasons not to ultimately continue manufacturing that drug. And so we were able to transition Sadie into an expanded access program for a short period of time to continue to receive access to the drug. But ultimately, the drug became unavailable. And in the intervening 4 years since that's happened, Sadie has declined and she's lost skills. She now has some language still and can fill in words in songs, but she's lost a lot. But we continue to work I see her multiple times a year, and every time our focus is, is there something new that we can be thinking about for Sadie, or are there kind of in tandem, are there ways that we can be making Sadie's life, her quality of life, better at this time? There's so many lessons that Sadie has taught me, as well as her patient community as well, but we'll get into that in a minute, because that is more of where I spend my time now. So if my professional life was summed up by ears, butts, and throats for all of those years, not all of those years, a handful of years, and then this nagging sense of, you can't do it all, Liz, really drove me to this place, and these children that I've told you about really shaped me. The wheels now are driven by a very different set of priorities. And this is where I talk about not being able to do it all. So as I came out of fellowship and was looking at a faculty position, I knew I couldn't do it all. I have a busy home life. I have a full family life. And I knew that to be able to give to these causes, these things that now mean so much to me, I wasn't going to be able to do all the other things. And so perhaps not surprisingly, that diagnostic odyssey is still there, right? I carried that baggage right on through. And I'll tell you about some unique things that I've had the opportunity to do, addressing the diagnostic odyssey on a larger scale. But I think the things that really kind of had me by the throat were these ideas of bringing novel therapies to kids and providing that hope that I think is so important in the rare disease community. And it's not necessarily hope of a disease modifying therapy or a disease. It may just be hope of providing more comfort for our kids who are suffering. So, or hope for providing a more inclusive future for our kids. All of these things, hope is all encompassing in that. Okay, so I told you before, this diagnostic odyssey for a child with a rare disease, it can typically last between 4 to 7 years, but we have tools in 2025 to be able to address this and for this not to be the case. So I want to tell you about a project that I have had the privilege of being PI for a study that's operating in North Carolina called Early Check, the Early Check program. So Early Check is a newborn screening research platform. It's actually been in existence since 2017. But what this project that we've been most recently, the study that we've been most recently running was a genomic newborn sequencing study that was really designed to explore the feasibility and the acceptability of doing whole genome sequencing in newborns. This is, we are not the only ones talking about this. This is, if you have a Google alert set for genomic newborn sequencing like I do, this is a very hot topic. But in the Early Check study, we utilize existing dried blood spots. This is an opt-in research study. So all birthing parents in the state of North Carolina have the opportunity to opt in to receive this additional level of screening, genomic sequencing screening. And it's not we are using a whole genome platform, but it is not screening the whole genome. It is screening for about 170 gene condition pairs, some of which are highly actionable. These are things that we screen for on standard newborn screening that we know if we intervene at a pre-symptomatic time, we can avert significant morbidity and mortality. But a handful of these disorders, our panel 2 disorders, were really driven by a different idea that these are not clearly actionable, but they may be actionable. You may have access to participating in an early phase or a late phase clinical research study or a clinical trial if you receive that diagnosis in a pre-symptomatic or an early symptomatic way, much like SADI. And as such, that Sanfilippo gene is on that newborn sequencing panel because we felt like if you receive that diagnosis, I would have research studies that you would be eligible to participate in. Similarly, Angelman syndrome wound up on there because there are potentially disease-modifying clinical trials that are recruiting down to age 0. And so genes like UB3A, the Angelman gene, MECP2, the Rett gene, SGSH, the Sanfilippo gene, and many other genes that cause neurodevelopmental disorders where the therapeutic pipeline is advanced enough that there may be treatments, potentially disease-modifying treatments, parents had the opportunity to opt in for screening. Interestingly, parents in North Carolina who opted in for this, the vast majority, if they chose to opt in for panel 1, they opted in for both panel 1 and panel 2. So you could choose whether you only wanted to receive highly actionable results and not these more kind of theoretical actionable results or possibly actionable results. Most families who opted in to Early Check opted in for both. There was also a third option that you could opt in for, which was understanding your child's type 1 diabetes risk. And so actually most families opted in for all three. Consistent with other studies across the country, we identified about 2.5% of our newborns, these again are presumed healthy newborns, to have positive screening results. And about 55% of those were confirmed to have a true actionable diagnosis. Some families received early intervention surveillance as a result of these. Some received management recommendations and specialist referrals. And some are now enrolling into clinical trials or clinical studies or receiving therapies that were eligible at some point in that first 2 years as a result of those. And while these studies, again, a driving force of this was not avoiding the diagnostic odyssey. In fact, that was a criteria that could not be a primary criteria in how we were selecting these gene condition pairs. But ultimately, we were obviating the diagnostic odyssey for these families. So while most of these panels across the country or most of these studies across the world are not looking at entirely neurogenetic disorders or neurodevelopmental disorders, there is certainly discussion about opt-in newborn sequencing for neurogenetic and neurodevelopmental disorders. Going back to Sadie. So Sadie, when I met Sadie when I was a fellow, she really influenced my decision to spend some time with the research team at UNC. So here in the middle, the tall guy is Dr. Munzer. He is a world-renowned clinician, researcher in the MPS disorders, the mucopolysaccharidoses, of which Sanfilippo is one of them. And so early in my fellowship training, I asked him if I could do a month with the research team. And again, this idea of not just making diagnoses and sending kids on their way and not having that longitudinal relationship, but really making a diagnosis and having the opportunity to lean in, offer therapeutic options, offer clinical research opportunities. I really got bitten by that bug. And it was clear from that point on that that was what I wanted to do. So when I took my faculty position in 2022, it was with Joe Munzer and his research group and that was kind of my first step into my foray as a clinical trialist. So over the last couple of years, since I've served in this faculty position, we've actually had an incredible opportunity to move our clinical research team out of the hospital and into our own space. And this was all done with an incredibly generous, grateful donor, family donor who gifted this program $10 million to have our own center that was focused solely on MPS disorders. As a rare disease parent, I've spent a lot of time traveling to Angelman specific clinics. I know the value of being in a place where the experts know your child's rare disease inside and out. You're not the expert in the room for once. You're the expert in your child, but there's actual experts in your child's disorder. So part of our center, one of the main pillars of our center is providing expert ongoing consultation and ongoing clinical care for our local kids. We provide standard of care enzyme replacement therapies. The MPS disorders are all caused by deficiency of an enzyme, and that enzyme breaks down a substance that when it builds up is toxic and causes this neurodegeneration. And so the enzyme, replacing the enzyme, allows for that buildup not to happen. But the standard of care enzyme replacement therapies only treat the somatic symptoms of disease and not the neurological symptoms. So much like Charlotte's story, there's still a lot of innovation in this area looking at disease-modifying treatments that treat the brain disease and stop the progression of the profound neurological disease. So through this center, we're also able to provide access to cutting edge clinical trials for next generation therapies. Those next generation therapies look like enzyme replacements that are tagged or fused to get across the blood-brain barrier. And so they do penetrate the central nervous system and deliver that enzyme to where it needs to go. And gene replacement approaches, as well as thinking about other novel approaches like RNA therapies. We also provide neurodevelopmental and psychological testing. You all know I am speaking to the crowd here. This is incredibly challenging to get in the community at times. To be able to get timely, neuropsych testing done for school placement, for even just for behavioral management. This is challenging to find and get insurance coverage for, and so this is something that we actually provide for the most part free of charge. So before I move on, the other thing that we've had the opportunity to create here with this MPS Center is really kind of a different paradigm for what healthcare looks like. So not only for the family, this is a place where people with MPS disorders can come and know that everybody gets it, right? Their child can elope the room and run into a nurse who's going to know how to be able to handle that child, or they're going to bump into another parent who knows how to wrangle that child back into the room, or any of my nurse practitioners or nurses, or any of the 28 people who are now on our clinical research team, everybody. And they're all loved, right? They know that they can go up to the front desk and get their Kit Kat bar when they're done with their infusion for the day. We have a playroom that is a sensory-friendly playroom. So after they're done with their infusion for the day, they can go, unwind with other parents, which is also really incredibly, we're able to kind of build community because parents are able to sit in the waiting room together while their kids are doing whatever they need to do to blow off steam and be able to commune with one another. But we're also kind of taking that same mentality onto the clinician and the staff side. So what we do is hard. We are working with a incredibly deserving patient community, but it's challenging. These kids have really difficult disorders, and it's emotionally challenging. And I never want to underestimate the emotional toll on my staff and my fellow clinicians. And so we've built a model where we see patients Monday through Thursday, and Friday is kind of everybody's time for themselves. You don't have to work in the office. You can work from home. Many of our staff work 410s, and so they get their hours in Monday through Thursday, and they have a 3-day weekend. And this really stemmed from, again, that idea that the last time that I was mentally well was when I only worked 3 days a week. I want people to feel empowered to be able to do that if you can get your work done. And we can protect ourselves and not do patient-facing care on Friday. That's incredibly important, and I think hopefully keeps us all from burning out. Because again, what we do is challenging. And again, perhaps not surprisingly, is the desire to give back to my patient community. And so I do also have the privilege of leading our Angelman Syndrome clinic, as well as our clinical trials team with fabulous colleagues. And we are able to provide much of the same that we provide on the MPS team. We provide, again, kind of expert consultation, ongoing clinical care, access to clinical trials. But as you can see with all of these pictures, I don't do any of this in a void. I do all of this in the setting of a giant team. And that giant team doesn't just afford me the flexibility of, being able to do what I need to do. It affords them that same flexibility. Nobody feels so strapped that, they can't take a day off because nobody else is there to pick up that slack. So my goal is again, to create this sustainable work environment. Okay, in our last 3 minutes, what has Evelyn taught me? She has taught me so many things. But she really, at the end of the day, I say this over and over and over again, she's taught me what really matters. And it's been such an incredible gift. All of my children have, but Evelyn, again, has kind of been the hammer that, if I wasn't paying attention, would come and wallop me over the head. My first takeaway always, and everybody who knows me knows this, sleep is non-negotiable. Children with Angelman syndrome don't sleep. So this is a profound statement. Without rest, nothing else works. And I tell people this. I sit in Angelman visits all day, every day, and tell people this, and they look at me like I have 18 heads. But it's my truth. I'm in my bed at 8:30. Evelyn is in her bed at 7:30. My children know, if you want me to snuggle, you got to get me out of the bed before 8:30, because after 8:30 is my time. I'm going to be reading. I'm not reading for work. I'm reading for pleasure. I sleep 8 hours. That's what my body requires. If yours doesn't, I love that for you, but mine does. And so for me, sleep is non-negotiable. For us, for a long time, Evelyn slept in a regular bed with, actually shared a room with Sloan, but around 5, a switch flipped and she decided that being in an open space was torture and she couldn't turn off. And so she got her first safety sleeper bed when she was 5, and she slept 12 hours the first night I put her in there. And my Charlie at the time, gosh, he was 2 and was so jealous. They still are. She has the coolest beds in the house. And when we travel, we take her travel safety sleeper bed. Because this is how she's most comfortable. And this is how I can sleep. And again, this is non-negotiable for me. Okay. Keep what matters. For me, for our family, traveling was really, really important. Matt and I, my husband, a huge part of our dating and our pre-marriage life was traveling. I'm incredibly fortunate to get to travel in my day job now. And we love to travel as a family. And so one of the biggest things that we were worried about when Evelyn was initially diagnosed was, how were we going to travel? Both, how was I going to feel comfortable leaving her to travel so that Matt and I could continue to travel by ourselves, but also how are we going to travel as a family? And Evelyn, if we hadn't figured this out, would have missed some really fabulous bodies of water all over the world. That is her thing. She wants to be in the water, and that's not unusual for children with Angelman syndrome. And she would have missed out on so much had we not figured out how to do this. I say figured out how to do this, we just did it. We've been burned a few times. There's been trips that were like, whoa, man, you kind of regret that. But on the whole, the vast majority of trips have worked. And, we figured out over the years the ways to make this happen. And it's, take your safety sleeper bed. Don't go anywhere without your safety sleeper bed. If travel is going to cause anxiety, make sure we've got appropriate anxiety meds to be able to help manage that situational anxiety. If taking, we always travel with our comfort things. That's worth whatever extra checked bag fee we got to pay to be able to get the safety sleeper bed there and whatever we're going to need for her to be able to be comfortable. And I'd be lying if I'd said it didn't dictate some of where our travel choices have been made. We said a long time ago we wouldn't go anywhere if there wasn't, at least a pool and a body of water, because that's what keeps Evelyn happy and sane and lets the rest of the family enjoy vacation. But and there's trips that we go on that Evelyn doesn't go on. If I know that this is going to be a trip, this took me a long time to get there. I felt an enormous amount of guilt about this. But, as Evelyn became older and her desires and her needs and her wants became more clear, it became clear that there was a certain type of travel that she wasn't interested in, that she didn't want to participate in, that was really stressful, that was only adding a different layer of stress, both because of physical limitations, but, I think also just anxiety of being out of routine, and not having these ways to be able to self-regulate. And so we had to get comfortable with that. It's not often, but there are times that we will have to travel and without Evelyn. I will say on the whole, that has largely felt like a treat to her, because then she is one-on-one probably with, a caregiver or my parents, or someone who's spoiling her rotten. Okay, the third, you've seen this throughout, build your village. I live in childcare, despite having a house that is not big enough. It's been our ticket. This won't always work, but for now it does. Like I said, we've built our village at the office and built our village at home. And I've learned the uncomfortable task of delegating. I am a type A female who thinks I can do it best, and it's hard to delegate, but I've learned that if I would like to be here for, the long haul to be able to do this, I'm going to have to delegate. And so I do. And lastly, the power of saying no. So in this idea that saying no to some things means saying yes to what matters. And this is really proven so true for me in the last couple of years of our life. It's so tempting to think that we can do it all. And I think we are trained to say yes and just do it. And I can do that, but I don't enjoy doing that. And I've realized how much more joy has come from saying no. My therapist and I joke that this is my year of saying no, and I'm no worse off for it at the end of it. It was an interesting exercise, and I've survived despite the discomfort. So let me empower you to also enter your year of no. Okay, I so appreciate your attention for my hour of sharing stories with you. Like I said, I don't claim to have all the answers, only what I've learned through the eyes of this beautiful child that I've lived with for the last 11 years. And I'm happy to answer any questions.
Dr. Jalazo, thank you for just an inspiring and engaging presentation. I think it's a message that all of us should be reminded of, that we can't do it all, but we can figure out what we want to prioritize and what's most important to do, right? And particularly for families, I think, as you're saying, who are often going through this early experience when they're getting this diagnosis of trying to think if they can keep doing all the things they used to do. And you can make some decisions about what you want to prioritize, but also your message, what I heard is the other resounding theme is there's always hope.
There's always hope.
There's always hope.
And there's always joy. I think that is what my families have taught me. That's what Evelyn has taught me, but I have seen it resonate even in some of these incredibly devastating diagnoses that I've shared with you. There is joy. These families have taught me how to, again, hold profound grief and joy in the same space and still have room for hope throughout it all. I feel incredibly privileged to have the job that I do and be able to walk this journey with families. I absolutely love it. But I couldn't do it without saying no to a whole lot of things, professionally, personally, across the board.
Absolutely. Thank you. So we have about 15 minutes for questions. So,
good morning, and you're so inspirational. Thank you so much. I'm curious because I have two girls that have a partial gene deletion in chromosome 2. that I'm starting to dive into more now that there's more complications. Is there a platform where you can just register to see if there's any other parents or people that have a similar case to see how we could help each other?
A couple of different things, or a couple of different pathways. I mean, this is a little bit of a do as I say and not as I do. The online community, I think, can be a daunting place. We didn't talk about that today. One of my big protect your pieces has actually been not being deeply engaged in my own patient community Facebook group for a lot of reasons. And we can talk about that a little bit. But I do think that I think the internet and social media allows really unparalleled access. And so I always am guiding people to, and I'll usually do a quick sleuth or have my genetic counselor just see if there are patient groups there. Because I think that's the quickest and easiest way. If it's really, truly quite rare, then and there's not groups yet set up there, or particularly for like certain genetic variants or certain genes, or there are things like Gene Matcher, where clinicians can kind of put certain genetic changes in and find other clinicians, and then the clinicians can help the families connect. Sometimes we do it that way if it's really ultra or nano rare, or we're not even quite sure if that gene is actually causing those symptoms. But I mean, I do think social media is probably the number one way that I find families connecting with other folks. And then if not, I mean, I speak for myself, but we have done we've tried to do a lot of that legwork if families weren't able to do that. So like, I'll go out to my geneticist crew and say, does anybody else have any patients who have this particular gene change? And do you have a family who's willing to connect?
Thank you.
Yeah.
Elizabeth, if I can just expand on Laura's question for a little bit, what's the best way, or is there an easy way for families to find out of children who have rare diseases, to find out about potential clinical trials for their children? Yeah.
Yeah. I mean, the best way, if there's an actual registered clinical trial, then it will always be on clinicaltrials.gov. That is like your search engine and you can go in there and put in any disorder, and it will tell you everything from natural history studies to enrolling clinical trials, previously completed clinical trials, terminated clinical trials. That's like, the federal register where everything lives. But the other place that I'll typically tell families is if your group is large enough to have a patient advocacy group, then if you're connected with the patient advocacy group, you're probably not going to miss any opportunity to participate in either clinical research or a clinical trial, because they're going to be, providing that information out to their communities. So I kind of have a two-pronged approach. If there's a group, make sure you're following along, and that doesn't have to be on social media. That can just be by email blasts or, whatever the different platforms are that different patient advocacy groups are utilizing. But there are also the kind of self-search tools like clinicaltrials.gov.
Thank you so much. It's a really inspiring talk. I have kind of two questions. One is, can you talk a little bit about screening during pregnancy for, conditions? And can you also talk about how families can understand whether the treatments they hear about are legitimate or valid?
Those are two really fabulous questions. So prenatal testing, the field has come a long way. If we take Angelman, for example, we are able to identify deletion subtype Angelman syndrome as, either even on non-invasive, like cell-free fetal DNA. So, first trimester testing where mom has blood drawn and this is commonly done, looking at trisomy 18, 21, and 13, and for identifying gender. That is where it is most commonly offered. But there are microdeletion panels that are not widely recommended, and so they're not widely implemented in prenatal testing at this time. And part of that is because the sensitivity of that testing is really quite poor. And so for a disorder like Angelman syndrome, while we can feasibly detect it, the likelihood that positive screening test is actually a true positive is quite low. And so it drives a lot of anxiety during pregnancy and potentially unnecessary procedures, diagnostic procedures like an amniocentesis, to to get a clarifying diagnosis when we don't have any tools that we're going to be able to use to intervene during pregnancy. Now, that I think that risk benefit will shift if at some point in the future we are saying we're going to treat in utero for Angelman syndrome, right? I mean, that people are talking about that. So it seems like the wild, wild west, but that is absolutely a topic that is out there for discussion, and some preliminary research has been done. But for many disorders, we can do testing in utero. It's just not widely done. Again, for the reasons that I've said. I think where the vast majority of prenatal testing is done is when we see fetal anomalies, around that time of the anatomy scan. If there are fetal anomalies, then we are seeing a lot of genetic testing and very advanced genetic testing being offered. I see kids all the time who had whole exome sequencing from amniocentesis at 22 weeks of gestation. So that field is definitely evolving dramatically. And I do think we're going to come to the point, we're not that far away from non-invasive prenatal sequencing, where we're going to be identifying free-floating fetal cells in mom's circulation and doing either targeted testing, looking for something, or doing something as broad as whole exome sequencing or whole genome sequencing. That is not ready for prime time at the moment, but we're not that far away. Your second question.
Sorting out legitimate versus not legitimate.
Oh gosh. Yes. This is a job that I take very seriously as a geneticist. I feel like that's my role. I feel like, and I tell families this all the time, if you want to send me a paper and have me read the medicalese and tell you what, give you my feedback on this, I feel like that's our job as a geneticist. The role of the geneticist is really shifting. I think as we see primary care providers be empowered to send some of this genetic testing, we will become less the diagnosticians and more the interpreters, and more the people who are not just interpreting the genetic testing, but interpreting the therapeutic landscape. And so a lot of what I do is sit with families and give my opinion about the therapeutic landscape in Angelman syndrome and in the MPS disorders, because that's where I feel comfortable. And this is an area that I think is really tricky. Most rare disease families want to talk to an expert in their child's rare disorder, and I think they deserve to, right? I want to talk to somebody who really knows the space inside and out. And that paradigm doesn't really exist in medicine, right? The only reason I can only focus on two different sets of disorders is because my time is fully funded by research. All the rest of my clinician friends are generalists. They have to know everything about everything, which then gets back to, I understand why it can feel unsatisfying to see that geneticist, because they're not an expert in your child's disorder. And so I do think, your geneticist should be able to answer some basic questions. A lot of families, I will say, we find who the expert is and you meet with that person. And I will say 9 times out of 10, when I've had a family who wanted to connect with an expert, if it was out of state, they couldn't facilitate either getting there, they couldn't do a virtual visit because of licensure. 9 times out of 10, I've seen that expert be willing to do a totally pro bono virtual conversation where they talk through the therapeutic landscape and answer all of those questions. And I really do feel like that's what rare disease families deserve, is to have that level of expertise when they're asking those questions.
So, Elizabeth, I think we have a couple of questions from the online chat, and I don't want to ignore our online participants. I think someone's going to read those to you, I do believe. Yep.
This is a question from Jeremy Anderson. I am a father with a son with autism, and around the time of revelation, understanding of his condition, my family faced the most stress ever. As the dad, I isolated, blamed, and felt like the only one qualified to help my son. What was your journey?
So similar. And I fight every day to not continue. I mean, there's still small parts of me that have that, nagging whisper of like, okay, well, you're the best person to do this with Evelyn. So, how come you can't do it all? How come you can't do that? Right. I remember those early days after diagnosis. I share this a lot with newly diagnosed families. I remember how dark those days were. I remember how overwhelming those days were. I remember feeling like life would never be normal again, that there would surely never be a day that went by that I didn't think about Angelman syndrome all day, every day. And in that same breath, I remember the day, like 3 months later, I don't remember exactly how long it was, but 3 months later, and in the 3 months, I was certainly quite isolated. But I remember that day, 3 months later, where I was sitting outside on our back porch and I looked to my husband, it was like 6 o'clock, and I said, I haven't thought about Angelman syndrome today. Today was a totally normal day. And I will say, 10 years in, 11 years in, I obviously I think about Angelman syndrome because I talk about it a lot and I see patients with it, but I don't think about how much it impacts my family now, because I think now more of what I see is the joy that Evelyn and her Angelman diagnosis have brought to my family. Again, the very real part of humanity that is how normal disability is. Like I don't know at what point in the journey, I can't pinpoint that point of kind of radical acceptance. But I do think that is when it stopped feeling as isolating. And that is when I stopped feeling like, you know what? I'm not the only one that can do this. And if I continue that mentality, I'm going to die trying. And in fact, she is better for everybody else that I allow into this journey. She's better for every single one of those au pairs that we've had. One was the impetus for toilet training. One was the impetus for communication device. Like these new people have walked into our life with a brand new, fresh set of eyes and said, hey, I want to tackle this. And they can, because they're young and they're energetic and they don't have preconceived notions about what can and can't be done. And so they come in and they're able to accomplish these things. And if I had said all along, I'm the only one suited to do this, then I think I would have robbed Evelyn of that opportunity. So I think that has been maybe the most freeing for me.
Great. We have one more question from the Zoom community, from Amy Guntner. How have you navigated workplace dynamics when you've encountered supervisors or others that are negative or punitive when you've had to leave or miss work to meet your daughter's needs, including a medical emergency? She's asking because she had something that has been challenging her as a mother of a child with autism and a professional.
That's a really good question. I won't say it's always been peaches and roses, right? I'm incredibly fortunate now to be in a position where I'm working in the neurodiversity space in genetics, and I think there's a different level of understanding. But I'm not gonna say that I don't still feel that, that burden when I do need to. I think I self-impose that more than supervisors at this point. Now, I have had people in positions of power make comments that made it clear that they assumed I had a limited capacity or limited bandwidth because of Evelyn. And I will say I had to learn to let go of that and see that as their problem, not mine. And I think I think at this point, I am fortunate to be sitting in a place where being a parent of a child with a disability is seen as a strength and an asset, because there are ways, when I'm meeting with a family, I can navigate the conversation about, diaper digging and poop smearing and things like that in ways that many of my other colleagues cannot. I have trialed every size of snap up onesie and backward zipping pajamas for nighttime Houdinis. Like, I think this has now been seen. It's now been proven that that's an asset, but there was definitely a time when it wasn't. And I think that I was underestimated, and I just had to let it go and realize that that wasn't me. But this is also sitting in this place after many, many years of therapy about some of those little workplace microaggressions and kind of what professional dynamics.
Well, thank you for that, Dr. Jalazo. And thank you for an inspiring, engaging talk.